have to present for, right?
15 minutes.
15 minutes, okay.
Hi, good afternoon, everyone, and welcome to our old friends, our new friends. Welcome to MRF HIV STI Echo. I am Dr. Boyce. I'm a facilitator this afternoon. To my left is Belinda White. She's a clinical psychologist, and she'll be giving our didactic today on supportive psychotherapy. And to my right is Dr. David Musa, who is one of our senior physicians. I can call him that, without having him blush too much, who is with it as well. We're very happy to have it because the case is going to be, I think, very interesting later on. I'd really like your input. So welcome to all our old friends, all our new friends. And it is about that time. So without any further delay, Belinda, take it away.
All right, good afternoon, everyone. As Dr. Boyce mentioned, I will be presenting a bit of information to you on supportive psychotherapy. So of course, before starting, we just acknowledge funding. And of course, this presentation is not intended to replace any personal medical advice. So our learning objectives for today are to discuss the history and development of supportive psychotherapy, define supportive psychotherapy, identify clients that may benefit most from supportive psychotherapy, identify the general principles of supportive psychotherapy, and finally, discuss the use of supportive psychotherapy at MRF.
So I just want to interrupt for one quick second. I'm not seeing the slides. I just wanted to make sure that everyone else is seeing them.
Okay, hold a second. Let's pull it up. Apologize for that. Everyone's seeing now? Okay.
All right. So a bit of history and on the development of supportive psychotherapy. So supportive psychotherapy emerged from the time of psychoanalysis. Of course, this was brought to the fore by Sigmund Freud, where this and psychodynamic therapy were the most commonly used modes of therapy at that time. It was identified where individuals who were unsuitable for the analysis that both modes entailed, but required therapy nonetheless. So, just to explain that a bit, supportive psychodynamic and psychoanalysis therapy, those modalities are most common at that time. And those, of course, do some significant exploration of an individual's unconscious mind. And so it requires a lot of analysis and a lot of work on behalf of the therapist as well as the patient or the client. And so you'd find that some persons, they're not equipped to have that sort of analytic conversation or analytic interaction. So for example, someone with an intellectual challenge, let's say they've had a developmental issue that has remained with them into adulthood, and that impairs their ability to understand and to comprehend and to communicate. Of course, communicative interactions will be difficult for them. However, that does not take away from their need for therapy. And so within that recognition of some persons needing therapy, but not necessarily fitting the mold, therein lie the birth of supportive psychotherapy, right? So although it is a less researched field than other forms of psychotherapy at present, it can be used in numerous clinical scenarios and settings. So just some more information. Supportive psychotherapy was considered as an inferior therapeutic approach at inception, right? So I mentioned how it came about. So it wasn't really considered a real therapeutic intervention, but rather just something to do for persons who couldn't get psychodynamic or psychotherapy. And so the persons doing it were not receiving any particular training. It was thought that persons who engaged in supportive psychotherapy, once they had common sense, good interpersonal skills, and the ability to empathize, they were able to engage in this type of therapy. However, as research progressed with time, although it's not a lot of research, but the research that does exist displays that supportive psychotherapy is quite effective, and even as effective as psychoanalytic, psychodynamic, CBT. So it was very, very effective. And therefore, the persons that engage in it, the therapists or the professional, they need to be particularly trained to engage in this type of therapy. So now we're going to look at the definition for supportive psychotherapy. It is a didactic treatment which uses direct measures to ameliorate symptoms and maintain, restore, or improve the client's self-esteem, ego function, and adaptive skills. The main objective is to help the patient cope with presenting symptoms and to avoid relapse of major illness. It is based on diagnostic evaluation, and the actions taken by the therapist are deliberate and are designed with specific objectives in mind. So some key things to point out and to pay attention to on this slide are the components of an individual or of the client that is really paid attention to and receives that support from supportive psychotherapy, which would be the client's self-esteem, ego function, and adaptive skills, right? And the second thing to pay attention to is the main objective. So the main objective is to help the patient cope with the presenting symptoms and to avoid major relapse. So I'm going to talk about this point particularly some more later on, because that really indicates the difference between supportive psychotherapy and other modes of therapy. And then the last line at the bottom there, in terms of it being based on diagnostic evaluation and the actions being deliberate on behalf of the therapist, that really indicates the difference between supportive psychotherapy and supportive counseling, which is something that is commonly used and spoken about in healthcare settings. So supportive counseling may be done by a social worker, nurse, or welfare officer, or any clinician really, and the client is given genuine expression of interest, encouragement, optimism, and a link to concrete services that they may need for their treatment, right? And this is, of course, readily available in most of these settings that all of us work in. However, it is important to differentiate that this is very much different from supportive psychotherapy. So a social worker may do supportive counseling, and it may look like just like what I've described, with that expression of interest, encouragement, optimism, etc., and linkages to resources. However, that is different from what psychotherapy is, and I will explain in more detail as we move forward what exactly psychotherapy is, supportive psychotherapy. So further breaking down those three elements that I pointed out to you before. Self-esteem, the client's sense of efficacy, confidence, and hope. Of course, efficacy, when we think of efficacy, we could think about Albert Bandura, who is a psychologist as well, and he really put forward a lot of work in the area of social cognitive theory. And he says that efficacy is a person's belief in their ability to succeed in a particular situation. So I think that is really a good way to explain how self-esteem works. And just a little additive to that, I explain self-esteem as a verb to my clients because I feel like it's more easily understood in that way. So the verb of esteem is to give praise to, so we could esteem, I could esteem my colleagues, right? And so self-esteem is really our ability to do that for ourselves in the face of adversity. So let's say something goes wrong. What is your ability like to esteem yourself and remind yourself of your inherent worth? And that is really what self-esteem is. It's a doing thing. And I find that my clients, they really understand self-esteem in terms of an action as opposed to an arbitrary thing that we're just trying to have or we're trying to obtain. When it's a doing thing, it is much more easy to grasp or wrap your mind around. Next is, excuse me, next is ego function. So this is in relation to reality, thinking, defense formation, regulation of affect. And lastly is adaptive skills, which is actions associated with an effective functioning. So, for example, let's say an individual walks into a room and they look at the people, they look at the setup, The way they perceive that room is their ego function. The way they interact with the room based on their assessment of it is their adaptive skills. And their feeling of, okay, I can do this or I can't do this, that speaks to their self-esteem. So that places it in a sort of a situational type of explanation for you. Next. So this is the final slide on defining, and it really summarizes everything that I would have said before, where the goal of and the aim of supportive psychotherapy is to maintain and rather than restructure. So this means that the intention is to reduce the symptoms being experienced and restore the client to their previous level of functioning. Supportive psychotherapy does not involve major life or personality changes. Reasonable defenses are not disrupted, conflict avoided, and critical feedback to the client is minimal. So this is very important because in other modalities of therapy, of course, we pay attention to, defense mechanisms that are used, and we really call those out, and we engage in critical feedback, we engage in some conflict may arise as well, depending on the therapeutic alliance and how strong it may be. However, those things are not necessary for supportive psychotherapy. So the goal in supportive psychotherapy is to provide support and to provide that nurturing environment where the client feels safe and they can experience the symptoms, the treatment of the particularly presenting symptoms. So as a psychologist, so many times when you sit in with a client, you see their presenting symptoms and you could automatically, with time, you could see where they come from. You could see those deep-rooted challenges that have been there from some time ago, maybe their childhood, etc. However, if I have chosen this modality and I recognize that this is the most appropriate modality for the client, then I am not going to step beyond the bounds and pry into that sort of unconscious mind, right? And those deep-rooted issues. I'm going to keep it at what is the presenting challenges and how we maintain and improve the areas that need to be improved. Right, so now client suitability. So of course, I just mentioned deciding that I'm going to do supportive psychotherapy for a client because this is most appropriate, right? So how do we make that decision? Supportive psychotherapy is useful for most persons, but it depends on what their presenting issue is, and it depends upon how impaired they are. So we can start on the left of the screen with the most impaired. So somebody who is on that extreme could be someone with an intellectual challenge, someone who has a psychotic illness, and that really impairs their level of insight or their ability to engage. And then you go to the moderately impaired. That could be someone with, let's say, depression, anxiety or so. And you can see the most impaired person receives strictly supportive therapy. Then you have the moderately impaired who receive supportive and expressive, or expressive supportive, right? And then the least impaired is expressive. So you may be wondering, what is expressive therapy? So with expressive therapy, the client is really encouraged to talk, right? It's encouraged to talk through problems openly, without restraint, and we really uncover and unearth the core of those, and we really delve deeply, right? Without bounds, really going into the unconscious mind and challenges that are maladaptive behaviors, maladaptive thoughts, etc. And the least impaired person is who functions well. So their level of functioning is not very much impaired. So let's say, for example, a doctor who's working really well in the clinic, maintaining their day job, maintaining their home life, but they're experiencing a significant amount of anxiousness, or they also feel depressed, right? And they need to talk to someone. So this person is not significantly impaired, and so some sort of expressive therapy could be engaged in with them, whether it be talk expressive therapy or non-verbal expressive therapy like art therapy, music therapy, etc. But then we go back to the left, which is the most impaired. So that's clients will benefit most from having interactions with a therapist that really just addresses their particular need at that moment. So simply explained, supportive psychotherapy may be most appropriate for an individual who is not suited for any other type of therapy. So CBT is not going to be appropriate for them. DBT, psychoanalytic, psychodynamic, person-centered, none of those are really going to be suitable for someone who doesn't necessarily have insight as an intellectual challenge. And so we're going to stick with supportive therapy. So I mentioned earlier some aspects of supportive psychotherapy that really sets it apart from supportive counseling. And these are, it's about 4 of them I have here. So the first is the therapist style. It's conversational. It is warm, genuine, and empathic. The therapist style, when engaging in other forms of psychotherapy, may be supportive and genuine, however, may be less transparent, as the main goal of the interaction is not solely to be supportive. And so my presentation as a psychologist, when I am doing supportive therapy, as opposed to a strictly CBT approach, of course, it will be warm and genuine because we want to develop that therapeutic alliance, which is the next point. However, a greater degree of transparency may be needed with supportive psychotherapy, right? Because you're really trying to foster that environment of warmth and genuineness and encouraging the client to feel safe, particularly for a client, for example, who has a psychotic illness. You know, part of having schizophrenia is maybe having severe delusions, persecutory delusions, maybe. And so you have to work really hard to build trust with that client, and your therapeutic style is really, really imperative to building that environment for the client. So next is the therapeutic alliance. So this is critical in most forms of therapy. It is a genuine connection of trust between the client and therapist. And it is critical for the success of a therapeutic intervention. If you have a poor therapeutic relationship with your client, then most likely they're not going to come back, or it's just not going to be successful, right? And so these two here are key indicators of what separates supportive counseling from supportive psychotherapy. Yeah, next slide. So treatment goals. These should be set upon commencement of therapy and mutually agreed upon by the client and therapist. It is important that the goals are based on the client's problems, symptoms, and priorities at the time. So in setting treatment goals, a lot of effort is made and a lot of time is taken to ensure that the client feels comfortable in recognizing what they want to address. And it's important for the therapist to really follow the lead of the client in setting these goals. So, for example, with CBT, there are particular things that you want to knock off the list with CBT because it's a very structured therapeutic approach. And so the therapist may have some influence in there. However, but in supportive psychotherapy, we really want to collaborate with the clients to ensure that their problem symptoms at that particular time is being met. Because remember, we're not doing any uprooting, we're not poking and prodding. We're ensuring that just what we see is being managed. And lastly, transference. So positive transference is nurtured and reinforced, and it is only discussed when negative. So this transference is the term that refers to when a client projects feelings onto their therapist, right? So in a therapeutic approach that is not supportive psychotherapy, we bring in this up regardless of if it is positive or negative. So let's say CBT oriented, DBT oriented, whatever it is, we bring in up transference because it's important. It's important for the entire therapeutic process. However, with supportive psychotherapy, we only mention it if it is negative, and we mention it in a very sensitive way. And there's a lot to be learned from positive transference in supportive psychotherapy in that approach, right? So the client actually learns a lot from the relationship that they build with the therapist. It's a little bit more tricky. And so those 4 principles really separate supportive counseling that a social worker, nurse, or clinician may do from supportive psychotherapy. So as you can see, there are a lot of details that go into supportive psychotherapy. Right. So we're almost at the end of the presentation. So you may be wondering why I wanted to do this topic. And truth be told, when I first started working here last year, I had a conversation with my supervisor, also a clinical psychologist, and I said to her, you know what, I don't feel like I could do CBT with these clients because they're not ready for CBT, and it feels like I'm gonna, hit the ground running, and I'm gonna talk about maladaptive thoughts and maladaptive behavior and identifying all these different things. And, it's just not gonna work. And she introduced me to this type of therapy, which is more appropriate, because within this sort of primary care setting, you come across clients with numerous issues. So of course, schizophrenia, somebody who's schizophrenic, CBT may not be the most appropriate approach for them. Someone with intellectual deficits, same. However, it doesn't take away from the fact that they need therapeutic support. And so therein lied my need to find another approach that I could use to provide service to the clients. So at MRF, supportive psychotherapy is often used, particularly with persons diagnosed with psychotic disorders and intellectual deficits. So it's used with personality disorders, etc. And it has been used in conjunction with CBT, where elements of CBT are integrated, particularly focused on understanding the impact of automatic thoughts and aiding clients in becoming more assertive. So the thing with therapy, it is very malleable, right? So you could use the different approaches in different ways, and you could sort of develop your own style based on what is appropriate for the client. So at the beginning of my interaction with the clients, I may recognize that, you know what, I really have to tread lightly. This client may not have as much insight, so the client really just needs support at this time. So we go to the supportive psychotherapy approach, develop our treatment goals, etc., etc. But then further down, as the therapeutic process continues and the therapeutic alliance is strengthened, I recognize, okay, I could introduce some sorts of CBT concepts. And so I may just talk a bit about thoughts, talk a bit about their communication, etc. All of those are critical parts of CBT. And so we have that integrative approach. However, it is done carefully because the goal is to ensure that as I mentioned at the beginning, is just to ensure that the client's presenting symptoms are addressed and not necessarily to transform the client or to bring about major personality or personal change, right? It's just to ensure those presenting symptoms are addressed to avoid relapse. Next slide. So we're on to the review. So supportive psychotherapy emerged when psychoanalysis and psychodynamic therapy were the most common forms of therapeutic support. It is useful in several clinical settings, not only for inpatient care, but outpatient care as well. It may be most appropriate for clients who are not suitable for other modes of therapy, but require therapeutic support nonetheless, and is much different than simply being supportive when interacting with a client, as it encompasses critical factors like the therapeutic alliance. So that brings me to the end of my presentation. And I pass it back over to Dr. Boyce, I guess, for questions or comments.
Okay, thank you, Belinda. That was an excellent presentation. I have to ask you what your technique is, because I think you do really, really good presentations, and I'm just... All right, so let's open the floor to any questions or comments that anyone might have at this time. I hope I didn't just close the meeting. Yes. That's from outside. All right. I wonder if you could just, because you're using CBT and DBT, or could you just explain the difference, so what they are and what's the difference between them? Because I'm not sure I understand fully myself.
Yeah. So CBT is often used for, let's say, depression, anxiety. It's really to focus on the connection between, so there's a triad in CBT, that's the focus, which are your thoughts, your emotions, and your behaviors. So you have this thought which automatically triggers an emotion and you behave a certain way, right? So CBT really breaks down that triad into ETPT steps. And it really helps the client to identify where their thoughts are triggering those depressive or anxious symptoms for them. And so therein lies the treatment, right? When you could address where those depressive and anxious symptoms are coming from, and they're really triggered by thoughts, and we identify what triggers those thoughts, right? So it's a very nitty-gritty process. DBT, however, is focused on relations. So let's say someone has borderline personality disorder, and they, a part of borderline personality disorder is having really having a difficult time with relationships, right? And navigating interpersonal spaces. And so DBT, the approach, while it does encompass some CBT things, some CBT elements, it's really practical. So it helps the client practice how they would engage and navigate in certain interpersonal spaces and navigate certain relationships, right? So let's say, for example, we may do role playing within the therapy room, right? To give the client that practice of how do we speak, right? Just practicing those interpersonal skills. Yeah. So while both CBT and DBT covers thoughts, feelings, and behaviors, and they cover relationships, etc., DBT, the style within which it is done is a bit different, and the focus is definitely relations.
Okay. All right. Thanks so much for that. Okay. So if there are no further questions or comments, we will proceed to the case this afternoon. I'll be doing the case, and I'm not seeing what Ed would say, but I hope you just join on, because this is something I think that might be right down his alley.